Well, welcome everybody and happy Friday. Thank you so much for joining us today for what we like to call Fertility 101. And it's just the basics of how to optimize your fertility for whatever treatment you're interested in doing. I'm Dr. Wendy Chang. I'm working today with one of my favorite people, Dr. Shahin Ghadir.
Hi, everybody. I'm Shahin Ghadir. Along with Dr. Chang, I'm one of the physicians here at Southern California Reproductive Center, and we are really excited this Friday afternoon to be presenting you guys with a general overview about fertility and getting you guys prepared for this journey and helping in any way that we can.
Absolutely. So I think, Jonathan, you have control of the slides. So as Dr. Ghadir said, he and I are at the Southern California Reproductive Center, and he has been an assistant clinical professor at both UCLA and USC. He's on the board of directors for highly esteemed organizations such as Path to Parenthood, previously the American Fertility Association, and he's been featured in multiple forms of media. He and I have been together at the Southern California Reproductive Center for about 15 years. And we're so happy to join you today. Southern California Reproductive Center has been in existence for almost 20 years. We have two flagships, one in Beverly Hills and one in Santa Barbara, but we also have satellite locations in Ventura, Bakersfield, Glendale, Pasadena, and Torrance. So we are 7 physicians across all of these locations. So I always like to think that there's a center and location at SCRC just right for every patient. The great thing about our center is that we are a fully functional, full-service fertility center. And that means that we basically can, in one location, perform all of the necessary testing and treatments to help you conceive and achieve your reproductive goals. Included in that is more than 25 years experience. In fact, cumulatively, we have about 100 years of experience among all of us.
You're making us seem too old, Wendy.
sorry. We're trying to look experienced, which we are.
We're experienced, but we're not that old.
Okay, exactly right. We're very spry. And we also benefit from state-of-the-art technology. Our founding directors, Mark Suri and Hal Dancer, I think set the bar in terms of taking the time, energy, and effort to create the best technology. And that actually has served us well for more than 20 years. We know that we are one of the few centers on the West Coast with time-lapse imaging or embryoscope. We've been performing and excelling at the most advanced technologies in assisted reproduction. We have an on-site surgery center. That means if you need polyp surgery, laparoscopy, that can be performed here, as well as full-service andrology, sperm testing, and hormone testing. We were among the first to achieve a pregnancy with sperm injection, and really the first on the West Coast. And our center was the first to perform genetic testing for an X-linked genetic disorder here in the United States. So we have a very storied past. And that is why we are also deeply involved in training the physicians of the future. So residents, fellows, and medical students from UCLA, USC, and Cedars-Sinai all rotate with us to get the benefit of that experience. You know, in the old days, it was very hard to afford fertility treatment, but fortunately, due to a lot of good developments in insurance changes over the past decade, there are now many insurance programs that we accept. And this is just a small list of what we do take. Especially highlighted here in this box include Progeny and Carrot, who many of our patients work with, and that's enabled many more people to afford the best forms of fertility treatment that can optimize them with respect to success rates and timeline too. We would be remiss though if we didn't talk about the pandemic. You know, we were actually closed for 2 months in an effort to reduce spread of cases and also to try to reduce the use of PPE to not add to the PPE shortage burden that was ongoing. But as of May, we have begun treatment for most patients. We know that this is based on a discussion between you and your doctor, and that ultimately, you know, the safest thing to do is what you two decide is best in your case. We know that there is still ongoing risk of treatment, but we're being exceedingly careful here in our center. We're screening everybody's temperature before treatment, and during treatment, we are actually having our patients do COVID testing through molecular technique. And we are still utilizing telehealth for most visits that don't need a physician exam or a physician treatment or surgery. And that means we are reducing the number of people walking through our center and reducing the risk that in treatment patients get exposed to the virus inadvertently. So let's talk about infertility. Keep in mind, everything we talk about today is towards the purpose of optimizing your fertility. So even if you've never tried and failed to conceive and you just want to optimize yourself for egg freezing or embryo freezing, these considerations and good methods still apply. But when we talk about infertility, a lot of people aren't sure what it means. And in terms of medical diagnosis and insurance purposes, we know that infertility is defined in the setting of a male and female couple as a year of trying to conceive with frequent intercourse without success for those under 35. And for those women over 35, it entails 6 months attempting to conceive without success. And that definition is quite important because it means that if you do have insurance benefits through your plan, that you don't have to wait a year if you're over the age of 35. But of course, if a woman experiences irregular menstruations, if she has severe pain, if there's any other abnormality that makes you suspect your fertility, you don't need to wait a full year or 6 months for evaluation. Generally, we know that the reason why fertility declines and why that timeline for diagnosis of infertility is shortened in women over 35 is because women are born with all the eggs we will ever possess. And that means throughout our lives, they are aging right along with us, exposed to all the cellular wear and tear, toxins, radiation that we're exposed to. Ultimately, what that translates into is a higher percentage of abnormal eggs or a lower proportion of genetically normal eggs. So if you look at a woman under the age of 35 and you test the embryos, you actually find out that, okay, under the age of 35, approximately 60% of the eggs or embryos will be chromosomally normal. But just in that small of a gap between less than 35 to above 35, the number drops to less than 50%. Much less when you're over the age of 40, instead of maybe 1 out of 2 embryos and eggs being normal, it drops down to approximately 1 out of 5. That's the main reason why we don't demand a long duration of wait for women over the age of 35. That's also the incentive for many people freezing their eggs. Once a woman is over the age of 43, it is not impossible to find a good egg, but the percent of chromosomally normal embryos really falls down to less than 5% range. Now, what is a basic fertility evaluation? We know that before you start any treatment, whether it's egg freezing or IVF or IUI, or if you just want to know where you stand, there's a basic foundation for testing. Number one, we review your medical history. Even though it seems kind of irksome to fill out a lot of paperwork and now you do it online, the benefit is we get a very clear understanding of all the medical and surgical factors that might be impacting your fertility, your hormones. We also will do physical examinations, and that will involve basically looking at the uterus, the ovaries, the abdominal, examination. All of this can give us clues about a woman's fertility. And then finally, diagnostic testing, and this will entail both blood and ultrasound, sometimes radiology studies. Bottom line is we're trying to assess a woman's fertility by understanding how well do the ovaries function, and that means does the ovary ovulate on a regular basis? Usually ovaries alternate and take turns ovulating. Once an egg is released, can the egg travel in the fallopian tube? That's where it's supposed to encounter sperm and get fertilized. And is the uterine cavity a good place for the embryo to ultimately implant? One of the most important tests in fertility testing is called anti-Mullerian hormone, or AMH. AMH is a hormone we never learn about in Sex education, you don't even hear about it throughout college. We didn't learn about it until we were in medical school. It stands for anti-Mullerian hormone, and this is a hormone that's produced by the cells that nourish and surround your eggs. So the more eggs you have, the more cells, the higher the AMH. And no matter what your age is, it's one of your best predictors for how successful a woman will be with fertility treatment and how many eggs she can make. AMH in combination with ultrasound to look at the ovaries and count the egg follicles is our best means of determining how strong the ovaries are. What about male testing? You know, semen analysis used to be pretty controversial because there are men with terrible sperm who can help females achieve pregnancy, and there are men with great sperm who cannot, because fertility is a two-party issue, egg and sperm driven. But we know there are basic numbers that reassure us this man is generating a fertile sample, and that would be semen that contains at least 2 ml of fluid. In each ml of fluid, there should be at least 20 million sperm, half of which or more should be swimming. And when you stain the sperm, fix them on a microscope slide and look at the shape, and here's the sperm shapes. They have to look at like that perfect tadpole shape. That kind of shape means good DNA is packed inside. There's good energy in the mid-piece so the sperm can swim, and a good tail to propel that sperm. The whole essence of sperm is to bring the male genetics into the egg. And basically what we know is sperm abnormalities are very common and getting increasingly so. Studies have shown that at least 20 to 30% of infertility is purely male-driven, and 40 to 60% of infertility is combination of male and female factors. So bottom line, this is a simple test that we can do to determine how fertile a man is and what kind of quality of sperm he's contributing. Before any treatment, we at SCRC have developed a program and coined the phrase NEST. NEST stands for nutrition, exercise, stress management, and timing, or what I also like to call toxin elimination. In the old days, if a woman had bad egg quality, we would say, gee, sorry, this is just how you're built, try again and again. Now we know that so many external or environmental factors like nutrition, vitamins, toxins can impact a woman's egg quality. So our goal is to optimize you before you actually begin with all of these factors. What about nutrition? You know, I think most people have a commonsensical notion that you gotta eat lots of vegetables, fruit, lean protein. And the answer is yes, that is absolutely true. In a study of more than 18,000 women, and these are reproductive age women who are nurses, so they already live a pretty healthy life, and you follow them and see who gets pregnant the fastest. Those that ate a lot of vegetable protein, beans, nuts, high fiber, and low glycemic index carbs. So more, sweet potatoes, whole grains, less rice, cakes, breads. They got pregnant faster, especially if they took a multivitamin that contained folate and iron. Other studies have shown if you're going to eat dairy, eat full fat, not low fat. Try to eliminate or at least reduce the amount of sugar and trans fats and alcohol. Those people who ate a Mediterranean diet seem to experience the fastest and best fertility. And if you eat a Mediterranean diet, you seem to have a lower chance of experiencing infertility or fertility compromise. So bottom line is we all know you are what you eat. Your fertility is based on what you eat. So I always recommend women eat lots of vegetables. Try to get 3 to 4 big servings, at least a cup each a day. Try to have 1 or 2 fruits a day. Lots of beans, nuts, if you can tolerate them, and try to reduce the amount of sugars you take in. But what's the nitty-gritty about vitamins? Lots of studies have shown us and supported the notion that certain vitamins benefit ovarian health and function. Among these are the Bs, so folate, B9, and vitamin B12, which you mainly get from eating meat. If you have good folate and B12 levels, you enjoy better fertility. So with a lot of, vegetarian or vegan patients, they might be lacking in this. Iron is also important for ovulation function, and women with very low iron levels tend to have more ovulatory dysfunction. So if your iron levels are low, and that comes oftentimes again from being vegan or vegetarian, you may want to supplement as well. Vitamin D, we all know, is so important in pregnancy too, and placental development. If your vitamin D levels are normal, you enjoy a 4-fold higher IVF pregnancy rate compared to women who are deficient. And this is easy, it's a no-brainer to supplement you. And then finally, even among women who have low ovarian function, the use of omega fatty acids like DHA actually improve egg maturation and quality. So these are all the same vitamins we tend to put in prenatals. They're the same vitamins we would use to prepare you for egg freeze. And then newer data have shown us CoQ10 supplementation seems to benefit the number and quality of eggs and how well those eggs get fertilized and turned into embryos. Guess where CoQ10 comes from? Also from meat. So if you have somebody who's pescatarian or vegan or vegetarian, it's highly likely they're lacking in B12, iron, and CoQ10. Those are the people I tend to supplement the most aggressively before treatment starts. And then what about the T part of nesting? Toxins. A lot of people don't know that excessive alcohol reduces your fertility, reduces the number and quality of your eggs. Studies have shown if you have more than 4 drinks per week, your IVF success goes down by almost 20%, more than 5 drinks per week by about 50%. So this is something definitely that's impactful. Similarly, cannabis not only disrupts ovulatory function, makes women more prone to have irregular periods, it also thins out the uterine lining. So especially when you're trying to implant an embryo, when you want that lining to be like plush and thick and rich, cannabis will work against you. And finally, tobacco, which we've known about for decades. Tobacco not only accumulates toxins at the ovaries, it cuts off ovarian blood flow. It certainly seems to reduce your AMH and your follicle count and success rates. So basically, we definitely have people avoid, and especially among people who want to reduce miscarriage rates, tobacco is impactful as well. And then finally, timing. People always ask, how long does a cycle take? Well, I always say, no matter if you're doing egg freezing or IVF, the treatment is about 3 phases. Number 1 is preparation, vitamins, nutrition. Number 2 is the medications. Oftentimes for women with strong ovaries, for timing purposes, for those with polycystic ovaries where you're trying to suppress testosterone, women will take 2 weeks of the birth control pill. This does what we call follicular synchrony. I always liken it to a horse race. When you're giving medications to the ovaries, you don't want one egg follicle to be heading in towards maturity faster than another. You want them all to be lined up at the starting line. So when you take the pill and then you stop the pill, it's like raising the gate of a horse race. Then the follicles will be growing at the same rate. You get more matures in one group. So after 2 weeks of the pill, you would stop the pill, then undergo about 2 weeks of hormone stimulation. These injections are pretty much identical to your brain hormones, but at a higher level. So we're hopefully going to be able to freeze 10 or more eggs at a time instead of 1 at a time. So usually the timeline will be after about a month, your eggs will be out. And Dr. Ghadir then will take over and talk about the rest of the treatments.
Thank you, Dr. Chang. So that was a great explanation of really important things that I really believe in. For my patients, I think making sure that you are living the healthiest life that you can live and doing everything in an optimized manner, I think is really under stress, and it's very, very important. All of those things, yes, unfortunately, a lot of those fun things like sweets and cakes and some alcohol and wine, all of those things to an extent can be detrimental. We're not saying to stop your life from doing all the fun things that you like to do, but really optimizing everything that you can do to help yourself is really, really important. With that being said, after all the diagnostic tests that we do here in our practice, all of the physicians like to make very specific treatment options for their patients. We don't do anything that is cookie cutter here, so no one's going to come in and follow A and then B and then C and D. Everything that we do from your testing lets us know what is the best treatment for you, what are the best medications for your plan of treatment, and how to proceed. In this picture, you see a lot of things happening. from the start of giving birth control pills to preparing the ovaries to make eggs, to taking the sperm and cleaning it, putting the egg and sperm together and making embryos, and then putting the embryos back in the uterus, and ultimately to see these two beautiful lines on the pregnancy test. So this is all really important things for us that we do in order to get to the process of being pregnant, but I'm going to go into more detail about all of this. Okay, got it. So, we want one too many. Let me go back one. So, fertility treatment options. There are a limited number of options of things that we can do for patients. One is a natural cycle where you just time things at home and you have intercourse at the right time of the month when ovulation is occurring. The other things that we can do is actually have your natural cycle of ovulation occur, but at the exact right time of the month, take the sperm and wash it up and inject into the catheter to get it as close to the eggs as possible. That's called a natural cycle with insemination. Clomiphene, otherwise known as Clomid, is a medication. We also have another option called letrozole. Those are both medications that we give to patients, and we can do artificial insemination as well. Unfortunately, it doesn't have a very high success rate. It increases the rates about 10 to 12%. The next process after that which in my opinion has kind of not been so successful and has been dwindling off, is between Clomid and IVF, which is the in vitro fertilization. There's a process of giving injectable medications along with the artificial insemination as well, which increases your chances by 19%. Now, the ultimate treatment option we have, which involves giving a patient medications to make a bunch of eggs, taking the eggs out of the body, putting it with the sperm, growing it in the lab environment, is the in vitro fertilization process. This statistic shows that we have a 70% success rates, but it's a little bit behind. As of 2019, every month we had ranged between 76 to 84.4% going to live birth, and that is a phenomenal number for us as a fertility clinic, and we are very, very, very proud of that. So ovulation induction is the process of giving a patient medication to help them release a bunch of eggs or an egg, whatever our goal is. This is very ideal for women that have difficult time ovulating, or they have irregular periods and need help to maybe kind of make this exactly formulated to release the egg. Usually this happens by taking about 5 days of letrozole or Clomid. It's a simple pill that you start on day 3, 4, or 5 of your cycle. And about a week or two later, when you're about to ovulate, we take artificial insemination, and we take the sperm and wash it up, and with a tiny little catheter, while you're in the pap smear position, we take this washed sperm and inject it into the uterus, and hopefully somewhere here in the fallopian tubes, this egg has released, gone in there, and is waiting for the sperm to meet with it. This is the process that occurs inside of the body. We have no control of picking the best sperm, picking the best egg. We can clean the sperm, release it, but everything else that occurs with this happens inside of the body. We're also able to give this injection called a trigger injection. It's called HCG to help release and help the timing of the release of the egg. But as I explained earlier, the success rates with Clomid and ovulation induction, there's something between 12 to 19% success. The next process that I wanted to talk about is the process of IVF. And the word IVF means in vitro fertilization. In vitro means outside of the body, and fertilization obviously is when we put the sperm and the egg together to fertilize each other. So when we talk about IVF, this involves us giving the female patient a series of about 10 to 12 days of injections. They're tiny little injections that we teach you, and we have you, sometimes they come in the form of a pen. You dial it to the amount that we say, you hold it against your abdominal skin, and you just kind of press, and it goes into the body. The number one complaint we get is people being worried about this, but once they've done it, they're not even sure if they're getting the medication because the needles are so tiny and they hardly feel anything when it's going into their body. We do observe that they do go into your body and they do respond, because as you can see when we're doing these ultrasounds, this is an ultrasound on the left-hand side of an ovary in the beginning of the cycle, And once those medications begin to go in, each one of these little casings, which are the housing for a single egg called a follicle, begins to grow. And we bring you back for blood tests and ultrasound. And when these follicles become a certain size, usually about 20 millimeters, something between 18 to 20 millimeters, we know that they are ready to be retrieved. And the patient goes to our surgery center where our anesthesia team is going to give a light little anesthetic into the IV. The patient's going to fall asleep for about 5 minutes, wake up, and the eggs have all been retrieved. There is a little needle that goes in on the tip of the ultrasound machine. It goes into the vaginal wall and through the ovary, and this helps just suction the follicular fluid, and the egg goes with it. And then we pass these test tubes to our lab, and at that... I'm having trouble hearing you. Whoa. My Siri decided to listen to me. I apologize. Anyways, the follicles go into test tubes to our lab, and at that point, we're able to get a count of eggs, and we know exactly what's going on with the number of eggs. At that point is when we can either freeze eggs, or we can also go ahead and put the sperm with the egg. So this picture is showing how, sorry about that. So this picture is showing two different ways of getting the sperm into the egg. Conventional insemination is when we wash the sperm, we just pour it on the eggs, and they do their own thing. As you can see, they swim and they get in, and usually the best one is the one that makes it in. On the right-hand side, ICSI, or intracytoplasmic sperm injection, that's the process where a needle picks up a sperm. The sperm is put under the microscope into a special medium that slows down their swimming. So our embryologists, who are the scientists inside of our lab, are able to look and find the best looking sperm with the nicest head, the nicest tail, and the nicest neck, put it into this special needle and inject one sperm into each egg. And there's benefits of doing this. And the benefits are that you don't get thousands and thousands of dead sperm on the outside of the embryo when you're going to be doing genetic testing 5 days later. And also, it gives us the capability of picking the best looking sperm when doing so. So when we take that sperm and the egg together, we're looking here, and it looks right here on day 1. Whether we're injecting the sperm or it's making it inside, we put the sperm and egg together, and we're checking for fertilization right here. And any embryo that takes gives us a little signal, and we know if the embryo has fertilized by looking at this. We watch these embryos grow. It goes from 1 cell to 2 cells to 4 cells to 8 cells, and it gets to be larger and larger. When it gets to about 16 to 13 cells, we call that a morula. It's a beautiful embryo, and it's on its way to get to where we call a blastocyst. A blastocyst embryo is the full-grown embryo that we get outside of the body. And at this point, once it's a blastocyst, we're able to do a couple of things to it. One is from the back side of the embryo, not where the baby is forming, but from the back side, we're able to do a tiny little biopsy. And that biopsy allows us to do what's called pre-implantation genetic testing on an embryo. Studies have shown genetically tested embryos, and we get reports back. Let's say you had 4 embryos go for genetic testing. Within 2 weeks, we get a report that says embryo 1, normal male, embryo 2, normal female, embryo 3, Down syndrome, embryo 4, chromosomally abnormal. All of the genetically normal embryos, and we can go to the next slide, that's actually a picture of showing how that little biopsy is being performed. So this is an embryo that's popping open. From the section that's popping open, that's going to become the future placenta and stick to the wall of the uterus to give the connection to the uterus and to the mom, a tiny little biopsy is performed from this section, and it's completely far away from where the future baby is going to be growing. That little biopsy is going to come back as a report. Embryo 1, normal male. Embryo 2, normal female. Embryo 3, like I said, abnormal. Embryo 4, Down syndrome. All of the genetically normal embryos that we get as a result of this procedure are then saved for you to use whenever you want. So whether it's the next month when your body is more natural and all the hormones have come out of you and you are doing really well, we can prepare the uterus. Or whether it's for baby number 2 or 3, 5 years, 10 years, we've even had someone use a frozen embryo 15 years later and have success. So these embryos stay there as long as you need them to stay there. That testing is called pre-implantation genetic testing. And what it does is it checks for chromosomal abnormalities, such as Down syndrome, Turner syndrome. If a husband and wife also carry certain disorders, for example, if two people carry the same disorder and have a potential of passing that disorder onto their child, we also have the capability of doing what's called single gene testing for that specific disease, so we guarantee that the child will not have that disease. We're also able to check tiny little differences and abnormalities in chromosomes that the mother or father may have, called chromosomal translocations. And this is the same test that we use that gives us over a 99.6% accuracy to actually pick and tell you what the gender of the embryo is. So this is what's done for gender balancing and family balancing. So by doing this process outside of the body, it gives us a lot of control. National statistics have been about half of where we are now, but SCRC statistics have hit close to the 80 percentile when doing the genetic testing, which is called PGS. The most advanced version of it is called next generation sequencing. And as you can see, we do that and it increases our results. With SCRC's technology in our IVF lab that we are very proud of, it's hit around 80% average, and we're very happy about that. Even if you are 44 years old, as long as you are able to make that one genetically normal embryo, your success rate will be very, very close to that 70 to 80% as well. So this is the #1 way that we have helped older, advanced maternal age patients be able to make those beautiful embryos and do everything we can in our power when it comes to the embryo transfer to give them success of implantation. Another area that has a complete dedicated division at Southern California Reproductive Center is our third-party reproduction. This is the area where individuals that need to use egg donation, whether it's a same-sex male couple or if it's a couple for some reason or another that the female egg is no longer functioning well, we have a process of helping people find egg donors. Anyone who needs sperm donation, we are able to help. Anyone who needs an embryo donated to them, we're able to help. And what's growing very rapidly in our country is the use of gestational surrogacy, and that's when someone else, unrelated to the genetics of the embryo, carries and delivers the fetus until live birth. Now, one of the things that I am very devoted to helping people understand and to do is fertility preservation. So many women, unfortunately, are unaware of the fact of how their egg reserve and their egg quality kind of declines with time. And this is something that SCRC has gone out of our way to educate people. When Dr. Chang put up those slides in the beginning of the insurance companies, it is so important for you to contact your HR department and find out many of the employers are now providing this kind of help for patients and providing services for fertility. Egg freezing is one that you should take advantage of. So we freeze sperm for anyone that's undergoing some whatever may be an issue that cause sperm problems or advancing age in men. Embryo freezing is perfect for couples that aren't ready to have kids, and egg freezing is absolutely important for anyone who's undergoing cancer treatments, extensive pelvic surgery, or just wants to electively delay and have complete control of having a baby on their terms and on their timeline. Luckily for us, the science of egg freezing has improved significantly, and we are very proud to say that we've had success rates that have been proven for women in their 40s. I personally have had a patient that was 44 years old, and a couple of years later, after she froze her eggs, came in and used them and had a beautiful baby. So we're very, very happy about that. Unfortunately, the egg reserve of a female from the time that you're in utero inside your mom at 20 weeks drops significantly upon birth, again at the first period, which is called menarche. And by the time a woman hits menopause, there are almost no eggs left to use. The good thing about using and freezing your eggs is that as your egg reserve continues to decline, whatever age you froze your eggs at, that's where your eggs kind of stay in and get frozen at. So it's basically, instead of going to have to use an egg donor when you're 44 years old, you can pull out your own 30-year-old eggs and give you that amazing success because the eggs continue to have that success that they did at the age where they were frozen. This is our IVF lab. Southern California Reproductive Center's IVF lab is called the ART laboratory. All of the physicians at Cedars-Sinai and UCLA Medical Center fertility divisions, along with 29 other doctors in the community, use our IVF lab. It's been rated along with our clinic to be one of the top 10 in the country. Our IVF lab is also the largest and has one of the highest success rates of all IVF laboratories on the West Coast of the United States. Everything we do in the lab is double witness verification, so there's never one set of eyes on your embryos or eggs or sperm. It's always two. Every single thing we do gives us the ability to grow an embryo to the blastocyst culture. We always use the fast flash freezing, which is called vitrification, which has increased success rates significantly. And the biopsies on embryos to do genetic testing is something that we use to teach different clinics here on the West Coast on how to do. We're able to do the sex selection. We're able to check for all of the chromosomes. And we are very, very lucky, as Dr. Chang kind of mentioned earlier, that we have what's called embryoscopes. Embryoscopes are the most advanced incubators that we have available. It takes 1,000 pictures a day of the embryo growing. And if we can show this video, basically it takes all these pictures, and after about 5 days, we can watch a video that tells us which embryo has divided the most beautifully and the most flawless, and that one giving us the higher chance of success. We also correlate the growth of the embryo to the genetic testing results. So when you look at both the genetics and structural growth of the embryos, we're really able to pick which embryo is our best embryo to give us the highest chance. The benefit of the embryoscope is we no longer have to move the embryo to expose it to air, to light, to movement. And statistics have shown by a gigantic study done around the world that an embryo that grows in the incubator without ever having to move it has up to a 20% increase in chance of implantation and pregnancy. And we're very proud because I think the last time I checked, there's only 16 of them in the country. And I think we're one of the only clinics on the West Coast of the US to even have them. So with that being said, this is an overview of everything that we do. We are more than happy and wanted to let you guys know that during this summer, unfortunately, during a very difficult time in the world with a pandemic, SCRC has gone out of their way to set some special summer packages together for egg freezing and IVF. We are very proud to be able to not only offer those, but also offer the highest technology and success rates on the West Coast of the United States. And we're very, very proud of this as well. At this point, both Dr. Chang and I are going to be here. If anyone wants to send any questions via the Q&A, we're happy to answer any of them.
I think there is one question about how reliable is the AMH test since it can be increased, for example, from 6.6 to 1.2. I get this question a lot, and I'm sure you do as well, Shahin. Remember, if you're getting it from different laboratories, there will be intra-lab variation. The test is basically assessed and measured against a standard curve. So if the standard for that lab is different, a 0.6 might be a 1.2 in a different laboratory. But if you do it in the same lab, yes, we do see variation. Certain medications, for example, using a lot of retinoic acid products, using spironolactone, being on the birth control pill for a very long time can suppress your AMH, and coming off of that suppression can improve it. So can stopping heavy alcohol and cannabis. So it is reliable, but you gotta compare the measurements in the same lab.
Yeah, and I think that's really a great comment. And we have to tell you, with that being said, and the variation from lab to lab, the AMH test is still one of the best predictors of everything that's going to happen in the fertility world for you. I think what I would take away from that is that there is one lab that has shown significant decline, and the 1.2 is a decent number, but definitely one that warrants you moving forward with treatment and freezing of the eggs. So both of those levels, in my opinion, and I'm sure Dr. Chang would agree, is to become proactive about what you're about to do.
Do you want to take the next one about sperm?
Happy to. So what age should men freeze sperm? And this, unfortunately, this is an area that has not been addressed tremendously in the world of fertility. But from the data that has come out, in the last few years, it has been shown that after the age of 40, there's significant increases in aneuploidy, which means chromosomal abnormalities. And there's a lot of things that can increase. There are even hints and suggestions of things such as autism that may increase. We recommend for men to freeze their sperm before the age of 40 and have that sperm available. If there's ever a time in your life that you may be traveling somewhere that you may get some kind of virus or infection that may infect your sperm, or if you know that you're going to have kids for sure in the future, but just not sure when, it cannot hurt to freeze your sperm.
I agree. I think the pandemic makes it important for men to consider freezing sperm too, because we know the testes have the ACE2 receptors that enable the virus to enter. And we also know if a man catches the coronavirus, it can decimate the sperm. So I have a lot of male patients who are just freezing sperm for that reason.
Yep.
And then Louise is asking, what is our take on coffee? And can it impact your fertility? There actually are studies from the 1980s that show the more coffee you drink, maybe the slightly higher your miscarriage rate is. Overall, we don't make people stop if they're trying to freeze eggs. We ask them to minimize or reduce. Of course, none is best because caffeine and even tea contains chemicals that can impact folate absorption. And we just said folate so important for ovarian function. So I feel like if you're addicted, start weaning. You don't have to go cold turkey right away. Sometimes that's hard. What you can do is cut down to half, then every other day and so forth. But it may be impactful based on some old studies in the 80s and then what we know about the biology of vitamin absorption.
So this is where Dr. Chang and I differ a little. She's a lot more strict than I am. I personally don't think that one caffeinated beverage, and I'm not talking about a Starbucks coffee that's this big, which has more caffeine than like 12
Not
cups.
the venti.
Yeah, exactly. So I think that one normal size cup of coffee made at home, I think is perfectly fine during the entire process and even after pregnancy as well. If people are very concerned about that, I tell them to go to a decaffeinated coffee, which still has some caffeine in it. But I think 1 cup a day of caffeine during this process is really not that detrimental.
That's the difference between a nice dad and a mean Asian mom.
Exactly. Our next question here says, thanks for your wonderful presentation and I hope, okay, well, and any hope for a case of non-obstructive azoospermia. So this is a very interesting topic. Azoospermia is the area that we discuss where a male partner has no sperm. We have some unbelievable colleagues of ours that we work with. And when we have worked with them, they do a procedure called testicular aspiration of sperm, or TESSI. And I got to tell you, I think I can count on 1 or 2 fingers in the last 16 years, people that were not successful from the process. So we're more than happy to refer you to one of our colleagues that we think are excellent and to help you with that process if you need that.
I have seen non-obstructive azoospermia completely reversed for people who use cannabis. That can decimate sperm counts and you can bounce back pretty quickly with cessation. So there are some environmental factors, although that would tend to be more rare.
I'll read it for you. Do the success rates shown reflect live births or just the IVF process? Do you want to answer that one?
Sure. So the numbers that Dr. Ghadir was quoting are our implantation rates, the times where we transfer an embryo and it takes and we get to the point of a positive pregnancy test. Depending on the age, whether or not chromosome testing was done, people may still experience miscarriage afterward. It tends to be under 10 to 20%. But the numbers he was giving you is every time we put an embryo in, what's the chance that we get a positive pregnancy test?
And one of the things I wanted to comment about is that at SCRC, because I want to say over 99% of our patients do the genetic screening, and also we do implantation failure panels before putting embryos back, most of the time issues that could potentially have caused the miscarriage are caught beforehand, and our miscarriage rate is actually incredibly low.
It's asking, what's the chance of successful pregnancy with a pedunculated fibroid? So I always tell people fibroids are like real estate. It depends on their location for maximum impact. A pedunculated fibroid means that if you think of the uterus like as a pear, an upside down pear, it's on the surface attached by a stem. Those tend to be the least impactful unless it's pulling a lot of blood and it's huge. If you have a huge fibroid over 6 centimeters, it can affect blood flow, but that would be very rare with a pedunculated. So if it truly is not impinging on the cavity, not distorting the uterine lining, not throwing off blood flow, the likelihood should be excellent.
Are there discounts for veterans or first responders? I want to let you guys know, anyone who's part of the VA or the Veterans Administration and attending there, they have an unbelievable program that covers up to 6 IVF cycles. So I would definitely consult with them. I have the phone number of the representative at the VA hospital that I can get you in touch with. For first responders, we're not turning anyone away these days, and we're here to help everyone. So as a group, we have made a decision to help everyone. So please, we want to address some of these things on individual basis. And at the end of your consultation or during your consultation with your physician, hopefully we can go ahead and refer you over to our new patient coordinators and also our consultants that can help you and figure out exactly what to do to make this work for you.
And I think they were asking, were we saying injectables don't have high success rates? And the answer is we're not saying that. When you look at fertility treatments, in the old days, 20 years ago when I started practicing, it was like a staircase. You would do the least aggressive treatment to try to get yourself pregnant. The injectables are between Clomid and IVF. And it's not that they're not successful. If you do Clomid with insemination, even if you have been trying without success for some time, the Clomid insemination gets you 10%. Depending on your age, the injections with insemination get you to somewhere between 12 to 19%. 12% if you're over 40, under 43, roughly 15 to 20% if you're under 40. But Kaiser is a big system that has a huge number of patients, so they're well equipped to do studies looking at cost efficiency. And one study that they did that was really interesting was they took women who failed Clomid and IUI, and they either made them do IVF or they did injections with insemination. And believe it or not, those that went straight to IVF wound up saving money because in the long run, it reduce the delay to their fertility. And if you don't get pregnant from Clomid insemination, it's less likely you'll get pregnant with injections. The other reason why we try not to do too much injections with insemination for women with strong ovaries is the very high risk of multiple gestation and what we call HUMP, higher order multiple pregnancies that give you a much higher risk. So we're not saying it doesn't work, it's just not as cost beneficial for people.
Right. And to be very honest, now that IVF has been around and it's accepted and there's tremendous amount of financing options and ways of making it work financially, there are not a lot of people in our office that want to do 3 cycles of Clomid and then 3 cycles of this, right. 6 to 9 months of their lives before moving forward. The next question was about a patient who has a low AMH who's attempted egg freezing on multiple occasions and it got canceled. I have to tell you, I think the number one recommendation I could give to someone like that is please get a second opinion. There are some groups that don't believe in medications such as growth hormone, don't do protocols such as the microdose flare protocol. These are all things that we have available to us here at SCRC and have helped people that I've seen medical records where they got canceled, and once they did processes here in our practice, did incredibly well, produced eggs, and were able to use those eggs to have kids in the future. So definitely get a second opinion. Some places are using, in my opinion, the wrong protocols for certain age groups and certain AMH levels and are not familiar with some of the newest technologies out there that we have to help you produce your eggs.
I think there's one mentality that people have a little bit opposite, which is people think if my egg reserve and egg numbers are low, I'm not a good candidate for egg freezing. It's actually the opposite. If you know your egg numbers are low, you have a low AMH, you should be freezing. Even if it's 1 at a time. I've had a woman who was on the cusp of 40 where you just get 1 egg at a time. She still wound up with a baby. So
one is better than none.
Exactly. You never know when it's the golden egg. And the fewer the eggs you have, the more you should be thinking, how do I plan out the egg freeze and the cycles?
Absolutely.
And then the next one is, what are success rates after a miscarriage within the last 4 months? Believe it or not, studies have shown that the presence of a previous miscarriage bodes better for fertility. It means that you've had fertilization, implantation, you got far enough along. So those women actually have better prognosis. So don't despair. But if you've had 2 or more miscarriages, then you just need a little bit more testing for other causes aside from age of the egg and chromosomes.
What is the rate of unsuccessful pregnancy with IVF treatment, and what is the #1 reason? I think that the rate of unsuccessful for us is, you know, I'm going to look at it differently. I'm going to talk about our success. Our success rates, as I stated, for 2019 were between 76 and 84% getting pregnant. So our lack of success is less than 20%. And the #1 reason for that is probably due to poor egg quality or poor sperm quality. And that's why we go out of our way to make protocols and to do all of the processes that we do in advance to make sure that your quality is tip-top before moving forward with the actual process. All of the reasons that we give the supplements, all of the assessments we do, all of the diagnostic testing we do is to get the best understanding of what's going on before starting the process, and we want to give you the highest chance of success. Also, lots of clinics do not do the genetic testing like we do. So there are clinics that are damaging embryos. There are clinics that don't know how to freeze the embryos and thaw them the way we do. And there are clinics that just don't believe in the genetic testing like we do. And I think that's what makes a huge difference in success.
I would say the most common reason for not getting pregnant then ties in with what Dr. Ghadir said. When we get a normal embryo or good, decent quality embryos, we're very successful at getting them to stick. So in my patients, the most common reason is you can't generate a good embryo. That depends more on age. The older you are, the less likely you are to make a normal embryo. But among the same age group, again, it's egg quality, sperm quality. You know, we've built a better mousetrap, but we need the raw components to be good.
You know, we've gotten so many great questions, Wendy. I think, unfortunately, we've hit almost the 2 o'clock hour and may have to go back to clinic. I want to encourage everyone to take advantage of our consultation specials that we're having as well right now during the summertime. We are more than happy to answer all of your questions. If anyone is interested in learning a little bit more about our practice, they are welcome to follow our Instagram and social media page, which is SCRC-IVF on Instagram and Facebook. If anyone wants to follow us individually, Dr. Chang, why don't you go ahead and give your Instagram page?
Mine is BH Fertility MD.
And mine is Dr. Shahin Ghadir. It's Dr. and then Shahin Ghadir. And it's on Instagram and Facebook. We wanted to thank everyone for joining us today. Thank you so much. I'm sorry if we didn't get to answer all of the questions, but hopefully we'll get into it much more detail when it comes to our consultation one-on-one. And we look forward to talking to you all. Thank you guys so much.
Thank you for joining us. Have a great weekend.
Bye-bye.
Bye-bye.